Okay. Welcome, everybody. Happy Tuesday. We're so delighted to bring to you a special webinar hosted by the Newborn Toolkit and partners linked to Born Too Soon. Welcome. Please introduce yourself in the chat. Next slide, please. So today we're having an implementation learning seminar series. Welcome to the Newborn Toolkit joint webinar community. Our aim is to build this to be a collaborative learning platform for faster progress so that we can grow together and move together for small and sick newborn care. Today's topic is, where is the money for newborns? Join the Newborn Toolkit to hear about webinars, news, share tools and ideas. So on the screen now, we have QR codes to sign up to the Newborn Toolkit newsletter, to sign up to the newsletter in French, and to follow us on all our social medias. That is Twitter, LinkedIn, and Facebook. Next slide, please. So we're having exciting upcoming events as we move towards World Prematurity Day next week. On the 14th of November, we have another exciting Newborn Toolkit webinar looking ahead, ideas for investment and implementation, where we will announce our essay winners and share key updates about the Newborn Toolkit. On the 15th of November, we have the NEST 360 BMC Pediatric Supplementation launch, which is an exciting group of papers highlighting the implementation learning experience from the NEST 360 hospitals. And on the 17th of November, we have World Prematurity Day, and there'll be many exciting events which will be cross-promoting on that day, such as the Digital Advocacy Hub that the PMNCH is launching on that day. So welcome, please introduce yourself in the chat. Next slide, please. I'll now pass the slide over to Lauren. Lauren, please.
D'accord, alors bonjour et bienvenue à tous les participants parlant français. S'il vous plaît, veuillez vous introduire dans le chat avec votre nom, votre profession et votre pays d'origine. Et si vous voulez écouter le webinaire en français, il y a un bouton au bas de l'écran sur Zoom et tu peux aller à la canal en français. Merci.
So welcome everybody, bienvenue tout le monde. We're so excited to have you here. My name's Joy Lawn and I'm going to be your host for today on this big topic about the money. And I want to start first of all by saying, well, why should we invest in these topics? Why does this matter for maternal, newborn, child health and stillbirths? Well, we know there are very big numbers, 2.3 million neonatal deaths, almost 2 million stillbirths, and still 300,000 maternal deaths. We know that there are gaping inequalities, and we've known that for a long time, and it hasn't really driven enough investment. But these are critical numbers for us to know and use. Importantly, we need to flip the narrative, because for these issues, the potential impact is massive. So making the case using data for return on investment. The costs, especially for setup to really do high quality maternal and newborn care, are not small, but the returns are major. And we'd like to highlight this paper that's coming in a couple of weeks on the Tanzanian investment case for neonatal care, which showed a return on investment of between $8 and $12 for every one invested. So we need to use data to make the case for investment. We also have goals. We have long-standing important goals for maternal mortality, newer goals in the SDG era for newborn survival. And while we don't yet have an SDG and should have for newborns, we do have for stillbirths, we do have global and national targets. And yet we know 63 countries are off track for the target for neonatal survival. About 50 are off track for the stillbirth target. So really critical that we go faster together, as highlighted by the Every Newborn and Ending Preventable Maternal Mortality communities. And then as we look at the news every day, the world feels like it's on fire. And in these crises, pregnant women and babies are the most vulnerable. This is a marker of health system and UHC. And within that, the most vulnerable citizens are preterm newborns. And the recent Born Too Soon report really highlights that that affects families in every country of the world. It isn't restricted to one region. It's an important issue for inequalities also in high-income countries. And that decade of action for preterm birth, which we're thinking about because of World Prematurity Day, the recent Born Too Soon report with many partners, many individuals, and really high-level leadership from within the UN and beyond, showed that there are lots of opportunities. We could go faster, but a critical gap is investment. So for World Prematurity Day this year, we want to not just wear purple, but use data to make the case for investment. We're able to get media reach, we have targets, but we need to move beyond that to get money and to implement. And so to do that, we need to use really thoughtful analysis that's just come out in 2 papers in Lancet Global Health to help us to understand different funding tracks. So there are 2 papers on donor funding for 18 years, on research funding across low and middle income countries for 10 years, and comparing that to global for 2 years. Spoiler alert, because you're going to hear more details, but the bottom line here is that in both cases, that the funding is still very, very small compared to burden, especially for high impact interventions. And so what I want you to do in listening to these 2 talks, and I hope you will download the papers, that the links will be in the chat, and look at the data and look at how we can make an evidence-based case for change. A big message is not just to ask for more money, but to have smarter money. We need to be more efficient. We need to not be reinventing the wheel all the time. And that's the principle here on the toolkit. Can we share things together and go together faster? We need to learn how to have fairer funding and make the case for that based on burden. And that doesn't mean we want less money for other things like immunization or malaria or HIV. We want to not compete, but find out how to have money used fairly to have a return on investment for families around the world. And then a very important theme here is the decolonizing agenda. Who has the power and the money? And I think this is really critical to have families and affected people at the table. I want to note that these papers both highlight a massive gap for stillbirth funding. There will be a separate webinar on stillbirths at a later date, and really critical. Because of the focus on World Prematurity Day in this short webinar, we'll particularly focus on newborns. So I'd like to then pass forward to the fantastic Megan Kumar. She's an assistant prof at the London School of Hygiene and Tropical Medicine and the first author on this paper on donor funding. And she's going to lead us through the findings of this paper.
Hello, everyone. It's my pleasure to introduce to you our paper on donor aid mentioning newborns and stillbirths, covering the period from 2002 to 2019. I'm speaking today on behalf of an amazing team of authors shown here on the slide, and this work was funded through the Nest 360 Alliance, and the full set of donors supporting that is shown at the bottom of this slide. So when we started to look at the availability of donor aid for newborn mortality, preventing newborn mortality and stillbirths, we first looked at the burden. There are over 2.4 million deaths annually, and the vast majority of these occurring in low and middle income country settings who might receive aid financing. We've seen a shift in recent years as newborn health receives increasing policy attention, including both at the global level, where we have a sustainable development goal regarding reducing mortality, as well as at the national level, with 78 countries now participating in having stated neonatal mortality targets of their own. We know something about the donor aid landscape. Newborn and child health, showing this as a relatively high level at $16 billion a year but stagnating over the last few years, and COVID likely having a persisting impact on that. And the prior analysis looking at aid financing for newborn health and stillbirth showed that there was very limited investment in newborn health and almost no funding in stillbirth prevention. So we wanted to see whether this change in rhetoric around newborn health and stillbirth prevention was going to be translated into financial commitments. So we took 3 sets of questions. One was on trends. So has the funding for either newborn, stillbirth, or the combined funding increased over the last several years? Who are the biggest funders supporting this, and who's receiving the money? And does that set of countries receiving the money reflect the burden? In order to do this, we looked at the OECD's creditor reporting system, what I'll call the CRS, going forward. And in that database, we found about 3.8 million records, among which we looked at specific flow types of official development assistance and private financing, and searched for mentions of a list of key terms, which is provided in the appendix of our publication. And out of that, we identified 21,957 records that benefited either newborns or stillbirths, among which only 46 mentioned stillbirth. So this is a great resource for others who want to look into aid financing. It's the largest aid database in the world, but it is missing some donors, including major donors such as China and Brazil. We used the Muskoka 2 methods, revised methods for attributing aid across both bilateral and multilateral financing. And we used manual searches supported by double coding. So what did we find? We found that aid for newborns in the context of the wider aid financing for the sector has not changed a whole lot as a percentage of the total. So over the last several years, from about 2009, we saw significant increase in financing for newborn health. But over the last several years, that has maintained around 10% of the funding for reproductive, maternal, newborn, and child health. And out of that, very, very little, much less than 1% mentions stillbirths. And again, this is mentions, so this includes both things that are newborn focused, as well as any aid that states maternal, newborn, and child health. If the word newborn, for example, appears in a phrase, it will still be highlighted as a newborn intervention, but it will be mentioning newborn health rather than newborn focused. And as we look at the newborn focused interventions, so we can see that the financing in this area is shown in red on the graph. It represents a very tiny fraction of the total donor aid in this area. So this would be interventions such as kangaroo mother care, breastfeeding, etc., things that are really focused on the newborn's health, as well as instead of focusing on either the dyad or the wider period covering early childhood. And what's important also to think about here is that these do not exclusively benefit the newborn, but they're focused on the newborn as the main recipient of the benefit. We know that almost everything at this phase affects potentially at least the parents and maybe others, or the child in later years. So what about stillbirths? We've talked so far primarily about newborn health and mortality prevention. So stillbirth prevention is even more significantly undermentioned and underfunded than newborns. So until 2009, we see no mention of stillbirth in any aid funding records. So out of that 3.8 million records we identified, there's no records even mentioning stillbirth. And then between 2010 and 2019, you can see that the picture isn't even. So there's a lot of ups and downs. The trends are not very clear, and it's only mentioned in 46 of the 22,000 records. which is about $45 million totally over this period. And we see this both as a missed opportunity, obviously, to invest in the health of, or I suppose in the well-being of babies in utero, but also a missed opportunity to count impact of other interventions in maternal health care, in infections in pregnancy that might avert stillbirth, but actually don't get mentioned in funding to do those things. And finally, who received the money? So we can see overall that there's low levels of aid per death. So we did this analysis over only the 41 least developed countries as defined by the UN, and 9 of those countries received $100 or less per newborn death or stillbirth in aid funding. There is a broad alignment. So you see the burden on the left, stillbirth in blue and newborn deaths in orange, and the aid financing to the right side. So there's a broad alignment, but there's large differences between countries with similar burden. For example, you can take at the top of the scale, Ethiopia with the most deaths over the study period is 3.9 million, receiving $820 million in aid, and Democratic Republic of Congo with almost as many deaths, 3.4 million, receiving less than half of the aid at $370 million. And the other thing to note about this is that there is, despite being least developed countries, there is a wide variation of income levels because development is not simply about income. So lastly, who provided the aid? There's a relatively small group of funders. So these are the top 10 funders. And primarily these are bilateral institutions, the US, Canada, and the UK representing the top 3, and the Bill and Melinda Gates Foundation representing the top philanthropy funder. And that makes funding in this area, although there are some positive trends, very vulnerable given the relatively small number of funders. So what does this mean? Basically, we have major investment in this sector, subsector of health, of MNCH, but there's a mismatch given the percentage and the number of deaths that are attributed to newborn death and stillbirth. Only 10% of the aid is coming in this area. And most of that aid is a broad category of aid rather than newborn focused high impact interventions. In the good news, the overall higher burden countries generally receive more aid funding, but the amount per neonatal death or stillbirth is still very low. And there is a vulnerability of funding in this area, given that the number of donors is very few. So going forward, we want to continue asking questions, first about the underlying reasons for persistent underfunding, the political economy of what is getting funded and why in reproductive, maternal, newborn, and child health. And secondly, how do we hold funders, both aid funders as well as domestic funders, to account to ensure protection for these important vulnerable groups? Thank you.
Thank you so much, Megan. And Megan is with us. So if you have questions, please do post them in the Q&A section of the webinar. We'll be answering live as we go through. So that was the paper in Lancet Global Health on donor funding. We're now going to move to research funding. And this is research funding around the world, and then with a particular lens on low and middle income countries. And really delighted to have Dr. Priyesh Agravat, who has pre-recorded also on behalf of the author team. And again, post your questions in the chat as we go through, and handing over to the wonderful Priyesh.
Hi everyone, my name is Priyesh, and I want to start by thanking the organisers for this opportunity to share our data with this network. In this webinar, I'm going to be talking about a project to map funding awarded for research that I and an amazing group of 7 people, including clinicians and academics, have been working on for the past 2 and a bit years. That was recently published in the Lancet Global Health. I want to extend a special thanks to all of the people here on the screen for all of their hard work and mentorship along the way. Without your work, none of this would have been possible. I also wanted to highlight that we've had some new additions to the team over this period, And so also wants to showcase the cute babies who have also been born over the time that we've been working on this project. Unfortunately, the little ones didn't fill out the Lancet authorship forms in time to gain credit on this paper, but maybe next time. We set out to conduct a review of research funding related to newborns and stillbirths, and we did so using a database called Dimensions. It's the largest research funding database with over 6 million grants. In simple terms, it can be thought of as a database similar to PubMed, but with additional data on funding, including where it is going to and from whom. In terms of what was already known, we couldn't find any literature mapping funding in this area, and after discussing with experts in the area, we decided on search terms and Boolean operators that we could use to find relevant grants. We set out to conduct the funding analysis with two main objectives. Firstly, we considered the big picture of what's happening globally with new commitments over a 2-year period. For feasibility, we looked at the major funders identified in the whole database with any newborn terms, defined as those who awarded at least 15 grants worth at least $5 million each, or to include smaller but more highly active funders, at least 75 grants worth at least $1 million each. Our second objective focused on any funding available over a decade that was given directly to or included an LMIC research partner. We wanted to hone in on the funding landscape where 98% of the burden lies. After identifying grants that were directly relevant through in-depth content analysis, we then categorized them according to research theme, research type, and we also looked at who the main funders were, as well as where it was happening. This slide summarizes our flow figure from the paper. As you can see, we reviewed over 10,000 grant titles and abstracts in detail overall. In the end, we were left with just over 3,000 included grants for our in-depth analysis for each objective, which I just discussed. In our first objective, we found that major funders awarded 550 grants worth $557.2 million on average per year. Of this huge sum, just 7.1% was awarded to institutes in LMICs, where we have established almost all of the burden lies. Another mismatch was that only 1.5% was awarded to research related to stillbirths, despite there being a similar number of annual stillbirths compared to neonatal deaths. The vast majority of major funders were from the USA or Europe, noting that 88% of recipient organizations were also based in Europe and Northern America, with 5.7% based in Sub-Saharan Africa. Next, our second objective, looking at LMIC funding over the past decade. Here's a beautiful ribbon figure Nuria made, showing funding flows for all grants with at least one recipient in an LMIC country. The ribbons show how funding flows according to World Bank economy groups for the host country of both funders and recipient organizations. We accounted for the distribution of funding where multiple recipient organizations are named, which is often the case with research grants, and we assumed there to be even distribution of funds when this was the case. We found that 83.4% of funding involving LMIC partners over this time period was awarded by HIC-based organizations, 14.2% by UMICs, and 2.3% by lower middle income countries. Of all grants with at least one LMIC recipient, only 67.7% of funding, 329.4 million, was directly available to LMIC recipients. Nearly a third was co-allocated to recipient organizations in high-income countries. So even of the large amounts of funding naming an LMIC recipient, vast amounts are being co-awarded to HIC institutions. We can see in the purple ribbon that upper middle income economies funded 68.8 million to others in the same group, which is more than they received from high-income countries. The median funding available per grant to LMIC recipients was $36,000, whereas the median funding available per grant in high-income countries was at least 18 times higher, at $662,000. Notably, very few grants had research partners in the lowest income countries. Focusing on this map showing the destinations of all grants with LMIC partners, we can see that those in the darkest shade of red represent countries with the highest number of active grants, those being China and Brazil. Interestingly, these countries also had the smallest median award sizes at $35,841 and $9,253 respectively. The bubbles here highlight the top recipient countries of those grants and the amount received, noting the UK to be a major recipient of research funding with LMIC partners. but that the BRICS nations are otherwise key leaders. The top 10 funding organizations and groups who funded LMIC research are also displayed, with the Bill and Melinda Gates Foundation being the lead donor. Over the 10-year period, the active funding available to LMIC research organizations almost tripled from 23.5 million to 68.2 million, as shown in this bar chart. Research themes receiving the most funding were neonatal infections, with 41.5% at $202 million, and complications of preterm birth, 9.1% at $44.4 million, which mirrored the global pattern. By health topic, this showed alignment of funders with two of the commonest causes of mortality for newborns, despite the mismatch previously shown with stillbirths. However, in terms of the research pipeline, nearly half of all funding went towards basic science or discovery, with 20.7% for interventional research, and implementation, which includes complex evaluations in health systems related research, receiving less than 3%. So to put everything together, what we found was that there is a lot of money being invested, and it's not just a case of saying in absolute terms that there is not enough money for research related to neonatal health and stillbirths. The good news is that, as we've demonstrated in the previous slides, there is money going towards LMICs, and it is increasing year upon year. However, despite this, when we looked at the data more closely, there are several overarching themes which I've touched on, and here are a few recommendations that we as an authorship group would make. Firstly, although LMICs are receiving increasing amounts of funding, within the global context, this still isn't at all commensurate with burden. And we found significant amounts being co-awarded to partner institutions, predominantly in high-income countries. This serves as an opportunity to drive LMIC-led work. Secondly, stillbirths were rarely mentioned in all contexts, and this will need to change if we are to achieve off-track targets for stillbirth prevention. Lastly, when it comes to the research pipeline, it's clear that there's plenty of funding for discovering and understanding problems. But given there's also widely published literature already covering this, with suggestions for interventions and implementation strategies that can operate in low resource settings, perhaps more should be going towards the latter two sections of the pipeline. Thank you so much for listening. And if you have any questions, I'm sure someone from the team will be happy to answer.
Thank you so much, Priyesh. And I see at the moment we haven't got any questions yet in the Q&A section. So please, I'm sure from these two papers, really important findings, and findings that are not just academic, they're findings that really show who's funding what and where and how that could shift. So please do put your questions in the Q&A section. Now we're going to move into a wonderful and really high-level discussion panel. Very honoured to have 4 special guests with us here who each bring a very important angle. And I'm going to introduce each of them in turn. They'll put their camera on, we'll ask them a question, they will answer, and then we will pass to the next one, but also encourage you in the audience to put your questions in the chat. So I'm going to start first with Dr. Nancy Lowenthal. So Nancy is the Office Director for Maternal, Newborn and Child Health and Nutrition in the USAID Global Health Bureau in Washington. She's worked in Africa, Asia, and I saw with interest that she has a PhD in behavior change, which seems quite appropriate to this. So Nancy, we saw on the slides from the donor funding paper that USAID is the largest bilateral donor for newborns, and we know also the largest in the world. We know that you were an early adopter for newborns and newborn funding. So I'd like to ask, how do you see newborn health within your priorities within the Global Health Bureau? And particularly, how can we have more funding on the high impact interventions? This is still a gap. So over to you, please, Nancy.
Well, thank you so much. So good day, bonjour. So it is a pleasure to be here along with my colleague, Dr. Leah Greenspan, and other esteemed colleagues from around the globe. We're representing the work of the US government through USAID programs. So it is an honor to address all of the colleagues from around the world who are dedicated to improving the lives of the most vulnerable populations to survive and thrive. We appreciate the researchers shining a bright light on the needs and gaps in investments in newborn health. USAID is committed to reducing the deaths of women under 50 and children under 5. We're focused on improving primary health care and recognize the importance of investing in the life course approach. We also firmly believe in one costed health plan developed by government partners that scale evidence-based, high-impact technical solutions to technical problems, and recognizing there is also a need for country political will that drives commitments to ensuring the healthcare system functions. And there are resources, that is, there are health workers, health equipment, commodities, medicines, and budget that are allocated in proportion to the need to focus on reducing the drivers of the greatest burden of morbidity and mortality. So given our sustained investments, USAID is pleased to learn that we are the top bilateral donor for newborn health. We also acknowledge the important and substantive contributions from other donors. 2 decades ago, global investment in newborn health, including USAID investments, were minuscule. The Lancet article shows how the US consistently increased its funding for newborn health programs from 2007 onwards, and has hovered above $400 million per year since 2011. We acknowledge that global resources, including USAID's contributions, is nowhere near the level that are needed to make a difference in achieving the Sustainable Development Goals for newborn mortality rate of 12 per 1,000 live births by 2030. We know that over 60 countries are off track to achieve the neonatal mortality rate goal. USAID's response is responsive to global health priorities and strategies. I'd like to share a few 3 examples of how we have actively engaged in and been influenced by global discussions and strategies. Perhaps the most important one is the development of a global action plan, the Every Newborn Action Plan, which articulated a shared vision that is ratified at the World Health Assembly in 2014, elevating newborn health as a global priority. It didn't stop there. The global endorsement at the World Health Assembly was followed by a series of national meetings that stimulated countries to develop their own national newborn action plans. These global and national efforts advocated for increased global and domestic resources. Another action that influenced USAID's prioritization is the robust data and trend analysis published in the 2005 Lancet series, followed by the 2014 Lancet series. So thank you, Joy Lawn, for co-authoring these seminal publications. As the global strategies for newborn health, the first decade of USAID's newborn health program focused on essential newborn care through community and primary level care. More recently, as the global community has begun to prioritize small and sick newborn care at district hospitals, USAID investments have also begun to reflect the same priority. USAID has prioritized coordination across multiple donors. We have been active members of the ENAP group, which has been instrumental in facilitating coordination of newborn priorities. At USAID, ending preventable child and maternal deaths is our overarching agency priority for maternal newborn child health, in the same way that our PEPFAR and so our HIV and malaria programs are USAID's agency priorities to tackle HIV, AIDS, and malaria. So our Presidential Emergency Plan for AIDS relief and our President's malaria investments are our answer to HIV and malaria. In 2014, USAID partnered with UNICEF and the governments of India and Ethiopia and issued a call to action to end preventable child and maternal deaths. That shaped our programs and investments. So with that, we have sustained that focus, and we look forward to any questions you may have and to some follow-up questions. So thank you, and over to you, Joy.
Well, thank you, Nancy. And, you know, many really thoughtful and important issues there, I think, especially listening to country governments. Really fantastic. And thank you to you, Leah, and also to Lily. Much appreciation. So we're going to leap from USAID as the top donor to India as the top leading country that many of us are learning from at the moment in terms of newborn health. Because in the analysis that have been presented so far, we've heard about donors and we've heard about research, but there's such an important leadership role for country governments. So India has this unenviable #1 for newborn deaths, but also has the most ambitious plan in the world and some of the most wonderful leaders. So I'm really honored to introduce to you Prof. Siddharth Ramji, Professor of Pediatrics, former Dean, and also, as well as his academic side, has really been a lead evaluator and also thinker within India's Every Newborn Action Plan that I know. So I'm going to pass you over to Siddharth to ask especially what can you share with us from India's investment in newborn care consistently and the really dramatic increase in speed for reducing neonatal mortality recently. Over to you.
Thanks, Joy. You know, I think the key to the continued governmental investment in newborn health has been strong and persistent advocacy by academia and professional organizations, especially the neonatologists, the Neonatal Forum. It's important to wind back a bit. I think India was one of the first countries way back in early 90s who segregated out newborn from the child health agenda and brought it to mainstream in the national program. And I think that was very critical for us because we realized quite early that unless we address the newborn survival, our child mortality or infant mortality was not going to come down. Right? So that was a very big issue. And that was something on which many of us very strongly felt. And as the advocacy grew, I think the important turning point for India to have the government's buy-in was when we got the then Prime Minister of India, Mr. Vajpayee, in 2000 to formally launch a newborn week, which will be celebrated every year and which we've been doing consistently since 2000. So I think that has, at the highest level of the political leadership, I think we got their commitment that they will continue to support and fund all activities that would move towards newborn survival. And the third thing that actually happened, which was very important, was that, you know, the initial days of our activities, when we realized that we have to not only have community interventions, but need facilities that should move away from tertiary hospitals and medical institutions to the districts. The initial pilotings were supported by the WHO, then the UNICEF, which led to the current numbers of newborn units that we see. We have a little over 1,000 special newborn care units in the districts at the moment, and which employs a little over 22 or 23,000 nurses and doctors who, as you said, are actually funded by the government. So I think the real turning point here was when the government decided to set up the National Health Mission. The whole idea being to ensure that there is universal access to equitable, affordable, and quality health care. And that began in 2005. And then it grew. It has a huge envelope. MCH is the major share of that funding. And of course, post-COVID emergency care has taken over. But today we have for the National Health Mission an envelope of about $4.5 billion US, of which about 0.9 billion US are spent on the support for salaries for the nurses and doctors working in our special care units. So I think it's a huge amount of money. Of course, this largely comes from the center, but one of the good things is that we had the buy-in of all the state governments, and there is some inputs for the state governments for infrastructure, but virtually, as you said, that the salary bill, the wage bill comes essentially from the central government. And I think one of the reasons why they continued to fund is the fact that as we kept giving new ideas and new interventions, they found that it was having an impact. So neonatal survival started improving, mortality started coming down. There was a strong commitment by the academia and the professional bodies to work with governments, both at the federal level and at the state level. And so over a period of time, I think we became largely capable of funding for ourselves. The other important thing we must remember is that we are not only funding for the SNCUs, we have a large outreach program called the Home-Based Newborn Care, and we have these community health workers, or actually social activists, whose incentives are also borne by the central government. It's a separate budget, which is over and above what I talked about. And the third, in fact, one of the purposes of the National Health Mission was to somehow reduce the out-of-pocket expenditure because we knew that newborn care is expensive, especially at the secondary and tertiary levels. And so, we now have, since 2018, the National Health Insurance, the Ayushman Bharat, the Prime Minister's insurance scheme, which covers newborn. In fact, very recently, last year, we expanded the packages, and even the amount of insurance that is required for newborn. So there is already a national commitment to ensure that no family should become catastrophic and go down the poverty lane if they have to look at newborn. Of course, this insurance covers the vulnerable, below poverty line population. So I think the key, as I see here, is that the academia and the professional organizations have continued to keep the advocacy pressure with the governments. Most importantly, they have worked together with the governments. We have done nothing in this country without partnering with the government. So even when we get donors who support, it is all rooted through the government, and there is a joint way of looking at how money can be best utilized. And so I think that has been India's story so far, and I think we have our funding by the government has been huge, and I think that it's essentially the fact that we have a commitment to ensure that we do reach the maternal and newborn targets for SDG by 2030. We certainly don't want to see that India remains top in contributing to mortality, but we also want to share the fact that we have success stories. And now we have also, I may share with you that we have today we have built capacity in industry to be able to develop newborn care equipment. And when India chaired the SAARC consortium, we actually donated newborn equipment to the SAARC region and actually carried out installation and training and establishment of SNCUs in the region. So I think it is not only that we have been investing for health for our own population, but we have also been supporting neighboring countries and anybody else who needs it. So I think as far as I'm concerned, the early buy-in of the political leadership and persistent engagement of the academic and the professional bodies with the government has been a key in ensuring that funding doesn't lapse. That's it. Over to you.
Thank you so much, Prof. Ramji. And, every time I, hear from you and from your colleagues in India, we learn so much. We all want to run faster, and, hearing the importance of putting different groups together, keeping the end in mind, the transitions of care, starting where you're at, but then building a systems solution, and just the impressive amount of funding. Thank you. Really important. And I hope that across the world we can learn and do more. So thank you. And we would love to have longer conversations on this. We're going to leap from India and the ambitious plan to get to an SDG of 9, actually, you're aiming to get to by 2030, to research funders. And if you remember the slide from Priyesh that he showed earlier, 10 top funders, the top was the Gates Foundation, and we really salute that. We also wanted to pick maybe people that, like in a good systematic review, we wouldn't have known were investing so much. So the EDCTP, which stands for European Developing Countries Clinical Trial Partnership, came in at number 5 with about 42 million over this 10-year time period. And, I think this is really important. We should be looking and saying, who are the people who are also starting to invest, as well as the people that we highly value that we know are investing. So many of you will know Prof. Marlene Temmerman. She has so many roles that we could have filled the whole page on this. And Marlene is speaking to us live from Paris, where she is for the EDCTP board meeting. She's a scientific member. She also has many other important lead roles. I think she's the only woman and probably the only man I know who is a clinician, an academic, being a parliamentarian and a UN leader. So Marlene, we'd love to hear from you live from EDCTP. Why do you think that newborn came into your priorities here? Why do you think EDCTP is funding at a higher level than some others? And what do you think could be done more, especially for the low and middle income country leadership, which we saw was a gap in these data? Over to you, Marlene.
Thank you, Joy. Can you hear me and can you see me? Because I'm taking this from my phone in a busy place.
We can hear you beautifully. Thank you.
Thank you so much. First of all, thanks for inviting me to participate in this exciting webinar. Secondly, congratulations, Joy, to you and to the team, because this publication, I know we talked about it when we were talking about the small vulnerable newborn Lancet series. But I was really impressed reading the reviews and reading the papers. So congrats, we need more of this. So then your question about EDCTP, maybe EDCTP is maybe less well known. As you said already, it stands for the European and Developing Countries Trial and Clinical Partnerships. And it started 20 years ago with a partnership between Europe and Africa, only on HIV, malaria, and tuberculosis. 10 years later, there was EDCTP2 that is kind of expanding to other infections and to kind of less common infectious diseases, mainly in African countries. But so I've been with EDCTP from the very beginning in different capacities. And now we are going to EDCTP3 Global Health. So we are here in Paris for our annual meeting, and this is really a big forum, a big conference, but also to kind of open the new EDCTP where global health is more important. Now, you will ask yourself, but all these infections and neonatal or stillbirth, how does it come together? It's mainly because during the second phase of EDCTP that colleagues, including myself and others, have put a lot of emphasis on maternal health and on newborn health, initially in relation to HIV, of course, HIV and the transmission, PMTCT, but and then later also postpartum infections, causes of maternal mortality, of neonatal septicemia, but mainly in relation to infections. So that's why we got at least some of the funding of EDCTP for maternal and newborn care. Now, going forward, we are here now and we have our governance. I'm a member of the Scientific Advisory Committee. So working with the other committees and with Europe and with the funding, we are trying to get in the EDCTP Global Health more funding for women and children, including, of course, maternal health, perinatal health, etc. It has been a topic in the call 2023. It will probably less clear in 2024 call, but again in 2025, it will be very prominent. So for all of you who are interested in research, because EDCTP is mainly bringing researchers together, and we would also like to expand into maternal immunization, vaccinations, you know, other areas. But the keywords are infectious diseases still. So there is much work to be done there. So I hope that is clear. Now, Joy, I would like, and with this community, maybe to address, and you know that you and me, we have been working together, publishing, like, you know, newborns, stillborns count, so we have to count them all, etc. We have done a lot of work in that area. As a former parliamentarian and politician, I would also like us to think a little bit more, because we all go with our kind of thematic passions, the mom and the newborn and the stillbirth and so on. And what I've learned, we referred already, or the previous speakers referred to the ENAP, which is great. I was at that time director of the Department of Women's Health and Research, so the RHR, HRP department within WHO, working together with the MCA department, a lot of overlap. But the point I want to make is, so we launched the ENAP, and then maybe, 6 months, 1 year later, the EPMM, you know, the maternal mortality. And we should, I think, avoid, of course, we want to get more funding for newborns, for stillbirth, etc. But we should not split the mom from the baby. I'm really impressed by the nest. You are the leaders of the nest, and I'm always calling for also a nest, a maternal innovation plan, because of course they have their specifics, but I'm happy also to hear from the USAID colleague and from our speaker from India that we need more money. We need more money for research, but I think we continuously have to make the point, if we talk about maternal mortality, in one sentence we talk about the newborn and the stillbirth, and the other way around as well. So to avoid that we have like parallel and competitive demands for funding. It is very good that we have this separate analysis done in systematic reviews on how much initially, and show that there's only a little bit money going to stillbirth, which is so important. But then we should bring it together immediately with the mom and the newborn and the stillbirth. And before I end, I think we all are convinced, even when we did the Lancet series on the small vulnerable newborns, we have been arguing from the very beginning, one of the most cost-effective interventions to reduce maternal mortality, stillbirth, and even neonatal mortality is to have women agencies, to have the women the women deciding on how many children they want to, when, how often, etc. So we need to bring this together and have one joint agenda with women agency as one of the key elements. Of course, asking also specific funding for specific priorities. I'm going to stop here, but this is my contribution to the panel here. Thank you so much.
Oh, Marlene, Merci. and you can see in the chat, and also, you know, people clapping. This is so important. You know, the woman and the baby and the child are together, and the stillbirth is often lost in that. We need to shout together. We really agree. So important. We started with that, and we need to come to that at the end. And then your fantastic point as a parliamentarian actually is a wonderful segue into the amazing Doris Mollel. So Doris, we would love to invite you, and I know that you're about to rush off to meet the Prime Minister of Tanzania. You know, you have been a preterm survivor, you're the mother of a preterm, you're a leading advocate for mothers, babies and children together, as Marlene has said. What can you tell us about things that have helped you to advocate? And we're low on time, but so important to hear from you.
Hello, everyone. Thank you very much, Prof. I'm trying to switch on my camera so that all of you can see me. Well, first of all, let me start with how everything came into place. We are very much. Can you return that? Because I saw a note to open my camera, so I would love to see it again so that I can see it. Well, I'm glad first to have this session with you all, and very much glad for Dr. Nancy, Prof. Marlene, Prof. Siddharth Ramji for sharing all the beautiful experience. Well, for my side as an advocate, it has been a very different role and space, because I, as a champion for premature babies, myself being born with 900 grams, and then being able to grow and become a beauty queen of Tanzania. So I'm a former beauty queen of Tanzania. It has opened eyes to see the need to care premature babies, after myself knowing that it contributes up to currently 48% of neonatal deaths in my country. So my journey began with the foundation itself, the Doris Mollel Foundation, that was founded in 2015. So now it's 8 years. When I started, the first 3 years were really hard, because nobody would really understand what it means to care for premature babies. I remember even meeting politicians that would actually not be very much interested in that. And 2016 is when we started to start thinking of how best do we now knock doors in technical people and supporting us to at least now reduce the knowledge gap. Because one of the key things that the Born Too Soon report of 2012 was enlightening on how best we can support or can help preterm births reduction. So knowledge gap was very key, well bolded action to do. So I took in that first, and we started to speak to the permanent secretary of the Ministry of Education by then. So we wrote to request the incorporation of the knowledge into science and biology subjects. And then he referred us to the curriculum developers. But by then, the government didn't have a political way of amending the curriculum. So we moved into 2017, where we started discussions of amendment of maternity leave. And so stakeholders and us agreed that we're going to have 6 months for preterm mothers and at least 1 month for preterm fathers. Then we took it to the Parliament of Tanzania for the first time, with our very first key champion. Her name is Honorable Angela Kairuki, who was also born herself prematurely. So she prepared for us to meet the members of Parliament. It was well taken care in terms of them being interested in listening, especially it was a women parliamentary group. But then I didn't have enough power. So when COVID-19 hit, then we started to experience so much fundraising that we have to do for parents who did not have money to pay for their premature baby costs. So here in our country, I'm speaking from last year and other years in back, parents would go into their pocket to care for premature babies. It's so straightforward that even the private health insurers did not cover for premature babies. So we had requested the private health insurers. They have their own unity called Association of Tanzania Insurers. So they had a meeting with us, and it was very nice. Of course, it was not easy to convince them. It took us 2 years for them to agree to incorporate the preterm baby medical costs into the health insurance. but it was not just in the health insurance, but we at least wanted them to incorporate it in the health insurance of a mother. So for us, that was very, very exciting time for us. And we decided after COVID-19 hit, we decided to ourselves that we need all these key things, the health insurance, the maternity leave, the knowledge into syllabus, and then we also added to request the government to allow in surrogate mothers to support premature babies when their mothers have passed away or if they have been abandoned. So we decided to call it a preterm baby agenda. And 2021, we launched it by meeting all the members of parliament. It was a very big event that took us 3 days of explaining each why is important and bringing it to their interest. And we worked so hard, of course, with the speaker, the former speaker of the Parliament of Tanzania. So the Social Welfare Committee of Tanzania had now taken it to the parliament last year with a very big push and bolt. And that was February. By the time the budget was announced in June, the Minister for Health, her name is Honorable Umi Mwalimu, announced that the government now is budgeting for premature babies, which was one of our very, very key agenda and policy push for supporting premature babies. So we are very happy that now the government has budgeted 23.36 billion to support premature babies in Tanzania. So that for us is a very, very big milestone. I mean, we wouldn't have done it better if we didn't have politicians pushing it behind. But of course, it was sleepless night. It was also I going to their constituency, talking about it, donating equipment. So you can imagine the amount of fundraising that I had to do and visit about 30 members of parliament and their constituency. So it really took us time, but we are happy. So if at all I have to, summarize the journey of preterm baby agenda, I would say it took us about more than 6 years to just push everything to where it is right now. So as I speak to you, the government of Tanzania is amending its curriculum, and by 2024 we're going to have a new curriculum, and it's going to have premature baby knowledge in science and biology subjects in the topic of reproduction, where they'll speak more about pregnancy, and issues of premature babies are going to be well raised. So we're expecting the upcoming citizens of Tanzania will have a knowledge, and they will not align it with witchcraft. They will not align having a premature babies as a curse, because that's what is happening on ground. They think it's a curse, and fathers are leaving their mothers, or they're leaving their wives just because mothers stay longer, but also they think it's a curse in the family. So at least we are reducing that. And then we're also happy now that the government, the government insurance and the private insurance have incorporated the cost under the maternity cost. So all that beautiful stress is a work of the government with we who are the pushers or the advocates of neonates. But the most beautiful part of it is herself, Her Excellency Dr. Samia Suluhu Hassan, donating 20 million cash for premature babies last year on the World Prematurity Day. And she donated 50 million Tanzanian shillings equipments for supporting one of the district hospitals where in the Lake Zone. So that alone is a very, very great investment. But also just 1 week ago, I was there as a premature mom exhibiting on the NICU, in the NICU. And then it was an event where we were launching a Tanzania demographic report on maternal and child care. So when she passed in our exhibition rooms, we had only 3 exhibition rooms: maternal and NICU plus sexual reproductive health. So she was very much interested, and she gave her own testimony that, her grannies, she did not know what it means to have a premature baby until her grannies were born prematurely, and her grannies were born last year. So for me, that felt really nice. And she recommended that she personally said, we are very much glad that you are speaking about these premature babies, but we all did not understand until it all came to our desk. So even this year, July 6th, we had an event with the Vice President of Tanzania. He also donated 20 million shillings to support premature babies, and he had a commitment to continue supporting it. So we feel good that now also that has motivated and inspired the president of Zanzibar in Tanzania to also show his investment in care for premature babies. So if I take back the history 8 years ago, where nobody had an interest to speak about premature babies and the reduction and how much it contributes to neonatal mortality rate, to now every politician feels good to be saying it. Men are now talking that they were also born prematurely, because here in my country, men speaking that they were born prematurely, it was really a hassle. They find it and they connect it with them being fragile, or they think people think they're infertile. So there's so many things associated with all that. But yeah, I'm very much glad that, you know, the role of the government is seen, but the role of politician is seen, and the political will becomes a very keystone in pushing different political agendas. So now even the donors who are putting money in the basket funds of the health in Tanzania are now looking at investing on newborn care as a new trending program and activity of their in their institutions, but also they're seeing it as a trend in the government. So I'm expecting many funders and many donors and corporate social responsibilities coming from different institutions will be coming into supporting Born Too Soon. And I see that in the coming years, we'll be talking about reducing, the mortality rate of the neonates has really dropped down. That's what I'm expecting. And I see the role of our big work that we've been doing for all those years. So I'm very, very much delighted to be here. It feels very good. I don't know whether I've been able to see my face or no.
But Doris, we really thank you. Your face is beautiful, your words are beautiful, and I think you exemplify what Marlene was talking about, women agency. You've really used your voice and your power for change for other women and for babies and families and men. We're so grateful to you, Asante. And I'm so sorry that we're out of time. We could have run this webinar, I think, for another hour, but I want to thank everybody. I want to please, for those who are here, if you can clap for these fantastic 4 panelists. And we heard, from funders, from governments, from researchers and parliamentarians. We've heard from powerful women advocates, and we've seen the importance of keeping together the mother and the baby, but also using the data and using our voices and linking with governments. I want to thank everybody who's been part of putting this together. I want to really salute Megan and Priyesh and all the author teams for amazing amount of work, and all their additional babies who didn't get to be Lancet authors. I'd like to point out that this is such an exciting time leading up to World Prematurity Day. We're shouting for women and for their babies. We want to not just wear purple, but make sure more money comes. And Doris's examples and all the examples we've heard here from those on the panel are so critical. Please do join, please do pass this on. And thank you so much for joining. Please come on the 14th when we'll be hearing grassroots ideas, winners of the competition. We had many entries for investment and implementation, and then some very practical papers in BMC pediatrics afterwards. Please do also give us your feedback on what you would like. We're looking to what we do for webinars next year, make suggestions and join. And we're really grateful to Chiesi Foundation for helping us to do this in French. And I want to thank all the team, particularly Mbozo, Lauren and Toby, who've worked so hard on this, and all those involved. So thank you so much and have a lovely rest of Tuesday. And please do stay involved, share and use these data. Thank you so much.
You had a very good time.
Yes, Doris.
And Doris, thank you. Good luck with the Prime Minister.
Oh, thank you very much, Prof. Yeah, I'm going for the dinner now.
I know. I'll see you in Dar in 2